Okay, we're all set.
Great, thank you, Nicole. And welcome everyone to the TASC 90 call this afternoon. This is Tracy Morton with TASC, and I'm joined here by Cami Norland. Nicole Clement is also on the line from TASC as well. And we're doing a little bit different format today than our normal quarterly TASC 90 calls. They're generally just conference calls, but we had a lot of information that we wanted to have presented in this session today, and a lot of it's pretty detailed information too. So we thought instead of just sending out slides, we might as well do a webinar instead. So we'll be interested in your feedback with that if a webinar in the future for TASC 90 calls is maybe more beneficial than just the standard conference calls that we've been doing. So you'll actually receive an evaluation like we normally do via email, and if you have your 2 cents to share on that, we'd really appreciate that too. I'm just going to run through the agenda for today, and then we'll get started. First, we'll have a quick update from TASC, and then Mike McNeely will be joining us from the Office of Rural Health Policy to provide an update from ORHP. After that, Michelle Goodman with ORHP has some critical access hospital regulatory changes to share via webinar. And then we'll move into our topical presentation for today, which is actually 2 different topics. First, Cindy Dupree with Draffen and Tucker LLP will be talking about the recent IRS notice on community health needs assessments for 501c3 hospitals. And those are nonprofit hospitals. Many of the critical access hospitals are nonprofits, and so they'll have to conform to the IRS reporting requirements for community health needs assessments within the next few years. So we just wanted to go over what the IRS notice includes, which is open for public comment, I think, still. And although that isn't the final regulations, I think it's just good to kind of stay on top of these things so that we can all address the questions that we might receive from critical access hospitals. And then secondly, George Pink from the Flex Monitoring team is going to be talking about critical access hospital financial indicator reports. I know that George had a short opportunity to talk about this at the National Flex Conference last month, but it's a really important report that's going to be coming out shortly to all the critical access hospitals, so we just wanted to provide an update from George about what's in the reports, how they can be used, and kind of the timeline for when they're going to be coming. So with that, I think I'll just move into a short update here from TASC. First of all, thank you to everyone that attended the National Flex Conference this last year in Portland. I wasn't there, so it was sad for me not to be able to see you all in person, but I heard that it was a really great conference and that it was successful in sharing information and allowing everyone an opportunity to network together. As part of the conference, I know we spent a lot of time talking about MBQIP, the Medicare Beneficiary Quality Improvement Project. Just a reminder that that project starts at the beginning of September. And so if you're still signing up your hospitals to participate, that's fantastic, and I think that we anticipate that happening into the next year or 2 as well. But if you have technical questions regarding MBQIP, feel free to contact TASC or to contact the federal office as well. There are resources on MBQIP that are posted on the TASC website. If you just get to the TASC website and search for MBQIP, you should find all the resources that are housed on one page. Or we encourage you to log into the Flex Program Forum. And the Flex Program Forum, for those that might not be familiar, is a web-based location for those associated with the Flex program to log in and interact with each other and share information. And there are a couple things in the Flex Program Forum, particularly related to MBQIP, that aren't being shared in a different format. So if you're curious about those or interested in those, that's the place to get that. Also, we just encourage you to interact in the forum in general. There's been some great postings put up there by a couple different Flex coordinators and some staff from the federal office too. And so that's the spot to get that, and we really encourage conversation on there about different topics as they relate to the Flex program. It's an opportunity on there to share your draft documents and receive comments from your colleagues, or just to bounce ideas around or talk about policy or things like that. So we really encourage you to get on there. If you have any questions about how to log in to the Flex Program Forum, just give us a call or send us an email here at TASC, and we'll gladly walk you through it. The other thing that we kind of launched at the same time as the Flex Program Forum were the virtual knowledge groups. And those virtual knowledge groups, Flex Program personnel kind of self-elected to participate in those. There's 5 different topic areas. emergency medical services, health information technology, health system development and community engagement, quality improvement, and financial and operational improvement. And so you either signed up for those back in 2010 at the Flex conference or in 2011 through kind of a rollout through TASC, or even at the Flex conference this last month too. And so those virtual knowledge groups are kind of just a group of people that are collectively sharing a common interest in a particular topic. They've all met at least once via conference call in June, and then had an opportunity to meet face-to-face at the Flex conference. And so if you're interested in engaging in those, please contact TASC as well. And just a point of clarification between the virtual knowledge groups and the Flex program forum. The virtual knowledge groups, as I just mentioned, are a group of people that are sharing information and thoughts about a particular topic. And the forum is just a mode of communication. Last week, I sent out a FAQs document to the Flex program, kind of clarifying what some of those things are and how to subscribe or participate in those. Again, any questions, just direct them to TASC. I think with that, that's all the prepared updates I had from TASC, unless anyone has any questions. And again, it is *# to mute or unmute your line. Okay, if there aren't any questions, then we can move along, and maybe Mike McNeely is on the phone to provide an update from ORHP.
Yes, I am here.
Great. Hi, Mike.
Hi, how's it going?
Good, thanks. Go ahead.
All right, just a few things to talk about. I know after the Flex conference there were a lot of questions relating to the Flex guidance and then MB-QIP and so forth. I just wanted to give you a little update on the Flex guidance. We are targeting releasing a skeleton around November of this year to give you approximately 4 months to start preparations for the actual release of the true guidance in February. What has been happening is that the project officers have gotten together and reviewed the work plans of all the Flex grants, all 45 of them, and we're looking at models that we could link to possible outcome measures so that we can start measuring a little more of the impact. That was the first step. The next step, we're proceeding to a key informant group, which will be the Flex monitoring team and TASC and members of the project officers. After that meeting, we're going to go through what we've identified, kind of cull through some of the material to bring it down to something that's a little more manageable. And then we're going to target 3 phone calls that will be facilitated by TASC on the core areas of the Flex guidance. So there will be a quality improvement one, there will be a financial indicators, and a health system development segment. And we are going to let the Flex coordinators contribute. This will be your opportunity to participate, and we will give you plenty of notice of when the calls will occur. The biggest issue will be that this will be your chance, and we will evaluate it from that point and try to formulate something that will be released tentatively in November. The next topic is MB-QIP. A reminder, the launch date is September 1st. That's popping up here pretty quickly. And what we really want to do is celebrate the number of MOUs or waivers that we've received. At this point, we only have about 313 in our possession. So if you have MOUs or waivers that you haven't gotten to your project officers, we'd really appreciate it if you forwarded those on to your PO so that we can include that in our launch numbers. Again, you don't have to wait for them, and you just have to send them in as you get them, and that would be appreciated. The other thing is about the virtual knowledge groups and the Flex Forum. We're trying on our side to have a project officer assigned to each of them, basically to see what type of questions are so that we can address them. So that is something that we are actively pushing. And if you've been on the MB-QIP one, Paul has been addressing some issues. I know he's posted a few times. But that's kind of where we're at least on Flex.
Thanks, Mike. Does anyone have any questions at all for Mike or the office? It's *# again to mute or unmute your line. Okay. I think with that, I see that Michelle Goodman is on, so maybe we'll just move into her CH regulatory update. Thanks, Michelle, for joining us today.
Well, thank you for having me, and I will try to keep this as short and painless as possible. I hope everybody can hear me, and let me know with the chat if you are not hearing me. We have, I just wanted to do a quick payment regulation update on the different regulations that have come out in the last few months. There is more information that can, somehow the slides are advancing. There we go. Okay. There has been a lot of information that has come out in the last few months, and so it's been a really busy time for the department. One thing that I wanted to include that is not on the slides is that yesterday the White House Rural Council did announce that the Department of Health and Human Services and the HRSA will be issuing guidance to expand eligibility for the National Health Service Corps loan repayment program so that critical access hospitals can use these loans to recruit new physicians. We expect guidance on this to be released soon, and as soon as we find out about this, we will be sending all that information out to folks. So starting with the final IPPS regulations for inpatient hospital prospective payment system, this is for those acute care PPS hospitals, but there were some things that were included that did for cause. CMS is updating the acute care hospital rates by 3% market basket, and for those who do report quality data, there will be a 1% reduction for productivity adjustment and another 0.1 reduction required under the ACA. There's also a reduction of 2% for documentation and coding adjustment. This will be also included for those sole community hospitals and Medicare-dependent hospitals, which will bring the update for all hospitals to 1.1% and for rural hospitals to about 0.2%. CMS is finalizing to expand quality measures for 2014 and 2015. One of the questions that Catherine Miller, you just asked is if these slides affect cause. Some of the ones that do affect cause, I will mention in particular. At the things that I just mentioned just right now about the payment updates will be for acute care PPS hospitals only. So just to continue, the quality measures that are being expanded for 2014 and 2015, this is for the inpatient quality reporting program. This is for those PPS hospitals. They are expanding those quality measures to 59 measures for payment determination in 2014 and to 76 measures in 2015. They have also outlined the beginnings of the hospital readmission reduction program that was part of the Affordable Care Act. This is for PPS hospitals, not for cause that was statutorily mandated. Through this regulation for this year, they have they finalized the selection of the applicable conditions, which are AMI, heart failure, and pneumonia, and the definition of readmissions. They will continue to make refinements to this program and include additional proposals in 2013 and 2014. Now, one thing that did affect critical access hospitals that was finalized in the inpatient regulation was that for cost reporting periods beginning on or after October 1st, 2011, if there is no provider or supplier of ambulance services located within a 35-mile drive of a CAW, but there is a CAW-owned and operated entity more than a 35-mile drive from the CH owned and operated entity would be paid at 101% of reasonable cost for its ambulance services. as long as that entity is the closest provider or supplier of ambulance service to the critical access hospital. So that had been something that was proposed, and they finalized it as it was proposed. Very quickly, for long-term care hospitals, I know some of you might be interested in this. That was also, the regulations were finalized in August 1st. There is an increase of about 2.5% to all of the long-term care hospitals, and they will be doing, starting a new pay-for-reporting program with a few, about 3 measures that they are going to be now required to be putting through. There were some changes to the length of stay requirements based on Medicare Advantage days, and also some change in ownership requirements that have been changed. If you're particularly interested in long-term care hospitals, just let me know. You can give me a call and we can discuss this more. For outpatient hospitals, the proposed regulation was published on July 1st, and comments are due August 30th. I want you to remember this, because this did have the proposed changes to the supervision requirements that I know many of you are very interested in. There will be a 1.5 update to all hospitals for the outpatient departments, with an overall increase to rural hospitals of about 0.2%. One of the things that CMS is now proposing to do with regards to physician supervision is that they are going to be extending the notice of non-enforcement of these regulations through calendar year 2012 for critical access hospitals and for small rural hospitals with 100 beds or less. They are proposing to use the current APC panel to make recommendations on supervision level and to solicit services or categories of services for consideration in changing that supervision level. In order to make sure that there is representation by rural stakeholders, they are proposing to add 2 to 4 critical access hospital representatives as panel members to the existing APC panel. These would not be voting members for the larger panel, but they would be part of the supervision subcommittee that they are proposing to do. CMS did also note that they have not yet defined the terms personal supervision and general supervision for hospital outpatient settings, except for general supervision as it is related to the extended duration services. And in this, they are proposing to define those terms in the regulation as the same as if they are defined for the Medicare physician fee schedule. Other things that don't necessarily affect critical access hospitals, but I thought you might want to know that they are making some additions to the value-based purchasing program. And expanding the quality measures for 2014 and 2015. They are going to be, they are proposing to extend the hold harmless transition payments for an additional year until January 2012. And they are also continuing to propose the 7.1 payment adjustment for rural Silk community hospitals and EACHs. For the physician fee schedule, the big issue on that is the sustainable growth rate. Under current law, providers would face a 29.5% cut for services in 2012. This is the 11th time that the SGR formula resulted in the payment cuts. All of these cuts have mostly been averted through legislation, so we'll see what happens in the next few months. And CMS is also proposing to have the RUC conduct a comprehensive 2-year review of all E&M codes, at least half of those in time for the 2013 physician fee schedule, which is hopefully expected to benefit primary care providers, which would be a good thing for rural. And they are proposing to implement the CDC-developed health risk assessment as part of the annual wellness visit, and are making some changes to the physician quality reporting system. They are seeking comments on how to improve physician care coordination following hospital discharge. If that is something of interest to you, comments are due August 30th. And they are proposing to add smoking cessation services to the list of covered services for telehealth services and to relax the criteria for adding Category 2 services. For ERX, e-prescribing, CMS is proposing to expansively define e-prescribing for the incentive payment and narrowly for the penalties. They're retaining the hardship exemption for rural areas with limited high-speed internet access and areas with limited pharmacies. And for those eligible providers that are lacking prescribing privileges, they would also be exempted, as would eligible providers in low volume with low volumes of prescribing. And they will start to put together the Physician Compare website in stages, beginning with PQRS measures. Now, since I think this is the last regulation that I wanted to touch upon, this doesn't necessarily have a direct link to critical access hospital to hospitals in general, but it is something that we wanted to have you all have it on your radar, and it is something that you might be interested in. The consumer-operated and oriented plans, otherwise known as the co-ops, the regulations were published on July 18th, and comments are due September 16th of this year. There are three main areas of this: eligibility, loans, and standards. The co-ops are private nonprofit issuers governed by their members and will sell coverage through the state's affordable insurance exchanges, as well as have the opportunity to sell coverage to small businesses through the state's small business health option programs, otherwise known as SHOP exchanges. You may have heard that term. CMS is proposing standards for co-ops and for qualifying for $3.8 billion in repayable loans to help start up and capitalize these new health plans. Co-ops will use any profits to benefit its members, including actions to lower premiums, improve health benefits, improve the quality of member health care, expand enrollment, or otherwise contribute to the stability of coverage for members. Applicants can apply for two different types of loans, the startup and solvency loans. So the startup loans would be provided by CMS to a loan recipient for costs associated with establishing a co-op and would be repaid in 5 years. The solvency loans would be provided by CMS to a loan recipient in order to meet state solvency and reserve requirements and would need to be repaid in about 15 years. This is a good opportunity for a viable rural co-op could afford rural consumers expanded coverage options, improved affordability, enhanced quality of care, and a substantive role in plan governance, and to introduce competition. There are a number of other regulations that were released that I won't be touching upon, and I didn't include on the slides, but there were at least 4 or 5 different proposed regulations that did come out around the health insurance exchanges. So if you have interest in any one of those, please feel free to call any one of us here on the policy team at ORHP. I've listed out the names and some of their issue areas. If you don't know where to send that comment, you can go ahead and just send me an email, call me, and I can help triage that question to the best policy analyst that we have. If anybody has any questions, I'd be happy to take them now.
And just a reminder, it's star pound to unmute your line. Okay. Well, thanks so much for joining us, Michelle. You can't take the slides as well.
Great. You sound kind of far away.
Oh, okay. I'm sorry.
Better?
So thanks, Michelle, for joining us, and thank you for the slide set, too.
Not a problem. I have to hop off the call to go to the negotiated rulemaking conference call. Joy. But if there are any questions that come up later on, just feel free to email me.
Okay, thank you very much.
Thank you.
With that, I think we'll move into the topical presentation part of our webinar today. And so I guess I will just introduce one speaker at a time. So first, Cindy Dupree with Draffen & Tucker is joining us to talk about the IRS notice on community health needs assessments for 501c3 hospitals. And Cindy is a partner with Draffen & Tucker and serves as the Director of Consulting and Compliance Services for the firm. Prior to joining the firm in 1988, Cindy served as the Director for Financial Analysis and the Vice President of Budget and Reimbursement for 2 large hospital systems. She's licensed to practice in Georgia and is a member of the American Institute for Certified Public Accountants and the Georgia Society of Certified Public Accountants. Cindy's an active member of the Georgia HFMA, where she served as a board member, chapter officer, and has earned fellowship status. She is a certified coding specialist and is a frequent speaker to healthcare organizations, including HFMA and hospital associations, as well as presenting in-house seminars to individual hospitals. Cindy has more than 35 years of accounting experience, and she recently presented for the Delta RHPI, or Rural Hospital Performance Improvement Project, on a similar topic, which is where we saw the presentation, and we're really impressed. Thought we should share it with the Flex program coordinators as well, because we anticipate that if you aren't already receiving questions about critical access hospitals and their nonprofit status and reporting on these IRS requirements, that you probably will in the future. So we just wanted to give everyone a heads up. I know that we're seeing increased activity here at TASC with community health needs assessments as it's starting to get on the radar of administrators, and so we felt like it was a timely topic for today. So with that, I will turn things over to Cindy.
Just a reminder, Cindy, you need to press *# on your phone to unmute your line.
All right, can you hear me?
Yep, just fine.
All right, great. Now, have you turned over presenter rights? Because
I will do that right
now.
All right,
thank you.
You bet.
All right, great. Well, good afternoon to everyone, and I know some of you, I can recognize your names. We're at the Mid-South Critical Access Hospital in Memphis, where I gave the same presentation, so bear with us as we go through this again. And what I'm going to do is go over the IRS requirements that were published on July the 7th, 2011. I want to point out these are noted as anticipated regulatory provisions. They are not even termed as proposed regulations at this point in time, but the IRS is asking for comments related to these regulations, and I will show at the end of this presentation where you can send those comments. First of all, what is the notice about? As I mentioned, it was released by the IRS on July the 7th, and it addresses the community health needs assessment requirements that were included in the Affordable Care Act. In this notice, it talks about some specific provisions that the Treasury Department and the Internal Revenue Service anticipate will be included in the proposed regulations. However, they are inviting comments from the public on this notice. These requirements are effective for tax years, hospital tax years that began after March 23rd, 2012. There are some hospitals who may choose to go ahead and start the process of conducting these assessments in advance of this effective date, and I would recommend that you do that if you're a hospital or you're dealing with hospitals, to recommend that they do go ahead and start this process. The process could take several months, and in addition, based upon what the IRS will be doing with this assessment, which will be looking at the community benefits that are being reported on the Form 990s, I would advise to go ahead and start this assessment so then you can have your community benefits strategy in place prior to this effective tax date. The IRS states that even though this is anticipated regulation to the proposed regulations, you can rely on the terms of this notice in performing a critical health needs assessment, as long as you make your assessment widely available to the public and you adopt your implementation strategy on or before the date. That is 6 months after further guidance is issued. And what that means is, if you do a community health needs assessment now and you follow these guidelines and this notice that I'm about to go over, then that will be an acceptable community needs assessment, even if the IRS changes the requirements down the road, as long as it's performed within 6 months after the date of that change. So pretty much you can go to the bank with what's in this notice right now. These requirements apply to every hospital that has 501c3 status and only to those hospitals that has 501c3 status. And let me go back and make a point here. There are a lot of hospitals that are governmental hospitals. They may be a hospital authority or part of a health district. Those government hospitals will not have to comply with these rules unless they also have Section 501c3 status. So even though part of the purpose surrounding this community health needs assessment is to more or less require hospitals that don't pay taxes, state tax, federal tax, property taxes, to require them to show some community benefits that are meeting the needs of the community in lieu of paying those taxes. We do have a situation where we have governmental hospitals who also do not pay taxes, but they are not required to file these community health needs assessments unless they have this 501c3 status in addition. I'm going to go over what I call the meat of the notice. These are the main things that the IRS and the Treasury Department will be looking for in the needs assessments. Now, I am aware, and I'm working with a number of hospitals who have already performed some type of community needs assessment and working with them to see, does it meet this IRS requirement? Now, one thing I want to make clear here, a community health needs assessment is not a marketing survey for the hospital. It is not a consumer satisfaction survey. It is a survey of the health needs of that community and the resources that are available to meet the health needs of that community. So I don't want anyone to, get off and not understand that. This is something different from a satisfaction survey or a marketing survey because its purpose is to focus on the health needs of the community. We're going to talk about the hospital organizations that are affected. What if the hospital is part of a system? What specific documentation will the IRS be requiring in the assessment? When and how to conduct it? The definition of the community and the requirements for community input. Also, what does the IRS mean by widely available to the public? An implementation strategy, how and when to adopt that strategy, the excise taxes, or what happens if the hospital does not perform this assessment, what are the reporting requirements back to the IRS regarding the assessment, and then the effective dates of the assessment. First of all, any hospital that is state licensed and is 501c3 will be required to file the assessment. That means even though you may be part of another disregarded entity or a joint venture or a limited liability company or a partnership, you are still going to be required to file if you are state licensed and 501c3. There may be some hospitals operating that are not state licensed, and the IRS will define the requirements on these facilities in future guidance. It is not yet defined in this particular notice. And this notice does not apply to a hospital facility that's located outside the 50 states and the District of Columbia. So if it is a hospital in Puerto Rico, it will not be required to follow these requirements. As I mentioned, government hospitals, there are some government hospitals that have dual status. They are governmental and 501c3. And what the IRS stated in the notice is the Section 501R, which is the Affordable Care Act section, did not explicitly address government hospitals, nor did it include an exception for government hospitals. So for that reason, the Treasury and the IRS intend to apply this community health needs assessment requirement to every hospital organization with a 501c3 status. So if you are governmental and you have the 501c3 status, in addition to being governmental, you will be required to perform the community health needs assessment. Right now, there are no exemptions for critical access hospitals. If you're critical access, your 501c3, you will be required to meet these requirements. Now, what if a hospital is part of a healthcare system? And we have a number of healthcare systems where you may have a PPS hospital, and it also has a critical access hospital as part of its system. Each hospital will be required to separately meet this community health assessment. Each hospital will have to do their own community health assessment, and they will have to document and write a separate implementation strategy, and we'll talk about that implementation strategy in a moment. That does not mean the hospitals cannot collaborate in performing the assessment. However, there has to be a separate written assessment and written implementation strategy for each hospital facility. Now let's turn our attention to the documentation. This is very important here. You have to have the community health needs assessment performed at least once every 3 years, and you have to have a written report to document that assessment. And this written report has to include 5 separate areas in order for it to be deemed acceptable by the Internal Revenue Service. And we'll go over what is the community, the process in which the assessment was performed, the community input, the prioritization of the needs, and the resource inventory of what is available in the community to meet those needs. For community, the report must contain a description of the community and how the community was determined. For instance, community could be a geographic area, such as a city or a county or a region within a metropolitan area. So it could be a geographical definition. The community may be defined by target population served, such as children, women, or the aged. For instance, I was in Memphis last week. We have St. Jude's Research Hospital in that community. That is a children's hospital, so their community would be far-reaching. It would go way beyond Memphis. That community would be deemed by the population in which it is serving. It also could be based upon the hospital's principal functions. For instance, if it is a cancer hospital, then once again it would not be a geographical area for their community, but it would be a community based upon that disease population. The IRS does state, even though you can define your community based upon the geographic area or the population or the disease, you cannot define your community in any way that excludes medically underserved populations, low-income groups, minority groups, or chronic disease needs. And I would say if you have a slide here, circle that really big, because those 4 community-type areas are throughout this notice, that it has to be included in your community health needs assessment. It has to be delineated in your assessment as to how these populations were considered and included in your community health needs assessment. Once again, they are accepting comments if there are any different types of community definitions that would be appropriate for this ruling. Now, the report has to contain a description of the process and the methods that you use for the assessment. A community health needs assessment is much more than just a survey that is distributed to the community and to receive community responses. It's much more involved in that, and the IRS wants to make sure that the report contains a good description of the process that was used and the methods that was used in that assessment, including identities and qualifications of third-party collaborators and any information gaps that impacted the hospital's ability to assess certain needs. When it talks about identities and qualifications of third-party collaborators, if the hospital brings in other parties or an outside consultant to help them with this community health needs assessment, then the IRS is going to want to know who it was and what qualifications that they had in order to participate in the process. And on the information gaps, there may be a particular health need in your community, but it's really difficult to gather good objective information about that need. So the IRS wants to make sure that you explain why there may have been some problems in gathering the data to address that particular health need. Now, when and how to conduct, as I've stated, you must identify and assess the health needs of the community, and you have to take into account persons who represent the broad interest of the community served. So you need to make sure that when the community health assessment is performed, that those broad interests of that community are outlined in that assessment, and there is discussion as to how they were included in their ideas and their thoughts and their needs that they see were included in there. You can include information collected from other organizations such as the Public Health Department. There are many states that require public health improvement programs or community health type assessments to be performed by their public health departments. It is perfectly fine and it is advisable when a hospital is doing a community health needs assessment to discover and to identify others in the community, other organizations who may have already gathered this type of data for whatever reason, and to review that data to see if it can be used in the hospital's community health needs assessment. The IRS and Treasury Department want to encourage collaboration with other organizations that may have already collected data to identify the health needs in the community. Community input is a must, and that's why must is bolded here and in capital letters. The IRS is very clear that the hospital must take into account input from people who have a special knowledge of or expertise in public health. And this would be, satisfied by including your public health department officials or other district public health officials in the focus groups or other type groups that you may be gathering to achieve and to get data regarding health needs. As a matter of fact, it states that the local health department must be included in this community input, also any regional state departments. Also, once again, here we're hitting these 4 areas that I told you to circle a few minutes ago. You must take into account input from leaders and representatives or members of medically underserved, low-income, minority, or chronic disease population, those 4 magic areas that the Treasury Department will be looking for. Now you may, this is not a must, you may consult and seek input from other persons in the community, such as advocates, consumer advocates, nonprofit organizations, academic experts, local government officials, community-based organizations, etc. This is a may. You may use these. However, the other must is that is a requirement to include these people. The IRS wants a description of how the organization took into account the input from the persons who represented the interest of the community. So how did you do that? How did you go about identifying the persons, the entities that you were going to include in your assessment? And when these were consulted and how they were consulted? Was it through meetings, focus groups, interviews, surveys, written correspondence? The IRS does not give a requirement on how you have to do it, but you need to be prepared to explain how these broad interests of the community were included in this community health needs assessment. Now, this is an area that's getting a lot of criticism, and that is the IRS requirement to identify the name of the organization and the name and title of at least one individual with whom the hospital organization consulted and the individuals who had special knowledge or public health expertise. They want the name, the title, the affiliation, and a description of the individual's knowledge and expertise. And like I said, this is causing a lot of controversy right now as to why are we having to put names, titles, etc. in this community health needs assessment. This is something that's a little different from what we've seen in the past. And like I said, I'm sure there will be comments sent in to the IRS because in some instances, people may want to remain anonymous as to their participation. Also, any individual provided input who is considered the leader or the representative of the populations, those populations being low income, minority, medically underserved, chronic disease populations. Once again, the IRS is asking for names and descriptions of the individual's leadership and their role in those particular areas. Very controversial with some people. Prioritization, it's not enough just to do the community health needs assessment. Once again, as I stated, it's not just a survey where you send survey material out, bring it in, and compile the results. The community health needs assessment has to include, once it's finished, a description of all the health needs that were identified and also a prioritization of those health needs. The IRS wants to know the process and the criteria used in prioritizing those health needs. So it's not enough just to file the report and say, here are the results. You've got to go through that prioritization process. And this prioritization process should have community input. It should not be performed in a vacuum by just the hospital personnel because these are the community's health needs, not just the health needs that the hospital will be addressing. That will be in a separate document. And the report also has to contain a description of existing healthcare facilities and other resources that are available within the community to meet those needs that were identified in the needs assessment. So once again, this is much broader than just the hospital at this point. This is, what is the community need? What resources do we have available to meet those needs? And where are the gaps? Where are the gaps in meeting the needs? Because those gaps is what we are going to be addressing in the hospital side through their implementation strategies. Now, this needs assessment has to be conducted in a taxable year or either of the two immediately preceding taxable years. So there's a 3-year window of time. One assessment is required every 3 years. It is considered conducted in the taxable year, that's the taxable year of the hospital, when that report is made widely available to the public. And we're going to define what widely available to the public means. However, in order to be considered conducted, the written report has to include all 5 of those elements that we just talked about. So if those 5 elements are not addressed in that community health needs assessment, then it is not going to be considered as conducted under these IRS requirements. What do we mean by widely available to the public? Bottom line, it's got to be on the internet somewhere. The hospital must post a written report of the findings either on their own website, or if they don't have their own website, the hospital mothership parent organization's website, or if there's one there, it can be posted on a website that's either established or maintained by another entity, as long as there is a link to report on that website with clear instructions on how to access the report. And it has to be available to any person requesting a copy. You cannot restrict to whom this health assessment will be available. The Treasury and the IRS considers posting on a website as widely available if 4 elements are met. And these are, the website has to give clear instructions on how to download the report. The report available must be an exact version. It cannot be a summary report or a condensed report. It has to be the exact full community health needs assessment. The public must be able to access this report at no charge and not require any special computer hardware or software. And I can tell you Adobe Acrobat is not considered special. So if you put it out there in Word or Adobe Acrobat, that would be fine. And you have to provide a direct website address to anyone requesting the report. So what you can see as we're going through there, this has to be a web-based report. It has to be accessible through the Internet. The report has to remain out there and available to the public until a subsequent community health needs assessment is performed and is available. And once again, the Treasury and IRS are asking for comments if there's any additional methods that could be considered as widely available to the public. Now, implementation strategy. This is a completely separate document from the Community Health Needs Assessment. We're finished with our needs assessment. It's published. It's out there on our website. The implementation strategy is a strategy that is specific to the hospital, not to the community. And the hospital is required to come up with a written plan that addresses how the hospital intends to meet each of the health needs that were identified through the Community Health Needs Assessment. So the hospital is going to have to look at that Community Health Needs Assessment. And remember, I stated in that assessment you've got to identify what the health needs were. The hospital has to tie back into that needs assessment, and for each of those health needs identified, they have got to have a response to that need. The hospital has to either describe how the hospital plans to meet that particular health need or identify the health need as one the hospital does not intend to meet and to explain why it does not intend to meet it. So the hospital is going to be held accountable to answer to every health need that is identified in that assessment, whether it can meet it, whether it intends to meet it or not. The hospital, on the ones that intends to meet, they cannot say, I just intend to meet this. They have to identify programs and resources that it will use to meet it and the anticipated impact of those programs and resources on the need. Now, they can collaborate with other organizations in meeting that need. The hospital does not have to meet that need on its own. They can state we're collaborating with the local public health department or the local school system, and we're doing A, B, C, D, E, and we expect that will result in A, B, C, D, or E. So you can collaborate, and I think collaborate should be encouraged. They state you can collaborate with related organizations. You can collaborate with other hospitals or other public health departments, state and local agencies. However, you must identify in that implementation strategy who you will be collaborating with and how you are going to meet that strategy. The hospital is going to be required to attach a copy of that implementation strategy to its tax return, its Form 990, every year in which it is filed. Now, there are some 501c3 organizations that do not file 990s, so they're not going to be able to attach that implementation strategy to anything. However, the IRS will be publishing some more information as to how those implementation strategies will be reported. This is just a little schematic drawing I'm showing you as to how this is going to work. The hospital will perform their community health needs assessment here. Based upon that assessment, it will be posted on the Internet. The hospital will file a separate report, which is called their implementation strategy, and the hospital will have to file a copy of that implementation strategy to their Schedule H on their Form 990 tax return each year. The strategy, it can be the same for each year but each year it has to be attached to the 990. So you don't have to do a separate strategy each of those 3 years. You just have to attach it to the form each year. The strategy is considered adopted when it is approved by the governing body of the hospital. So the board of directors, the board of trustees, however that is authorized within that hospital, that authority has to adopt that implementation strategy. Now, this is one very important thing to keep in mind when we're timing community health needs assessment. The strategy must be adopted in the same taxable year as the community health needs assessment was conducted. So if you perform a community health needs assessment in May and you're a June 30 hospital, that implementation strategy has to be approved and adopted prior to June 30 of that same fiscal year. And we've got some hospitals that have got some issues with this because they went ahead and did their needs assessment, not realizing that this requirement was going to be in the IRS documentation. So I'm sure once again there will be some comments made to the IRS regarding straddling of taxable years between the assessment being performed and the implementation strategy being performed. What happens if the hospital does not conform and perform the community health needs assessment? They will receive a $50,000 penalty for each year in which they fail to provide the community health needs assessment. So it may be you don't do the community health needs assessment for a 3-year period of time. You're going to get a penalty for each of those years. So there is some money backing up the need for the hospitals to do this. Now, I briefly mentioned that Schedule H. The Schedule H is not required by hospitals for the 2010 year. However, after that, it will be required. And this section, this excerpt that I am showing you on here, I just wanted you to see the tie-in between the IRS tax reporting and the assessment itself. On the IRS tax reporting, during the tax year or prior year, did you conduct a community health needs assessment? If yes, indicate what it described. Did it include the definition of the community, the demographics, the existing healthcare facilities and resources, that resource inventory I talked about, how data was obtained, that's the process as to how it's performed. Here on H, the process for consulting with persons who represented these information gaps we mentioned. This pretty much follows line by line what the IRS guidance is that we just reviewed. Also, a big square I've got here to highlight this section is, did the hospital address all of the needs identified in the needs assessment? If no, explain what was not addressed, why it was not addressed. So not only are they putting this in their implementation strategy, they're also having to attest to, answer these blocks on this Form 990, and someone's going to have to sign the 990 and attest to the IRS, yes, I am personally attesting that all of this was performed in the manner in which the IRS required. Once again, just remember that these questions are optional for tax years beginning on or before March 23rd, 2012. That March 23rd, 2012 is the magic effective date for this community health needs assessment. And once again, that you can attach the same implementation strategy for each of those 3 years. Once you have an implementation strategy, it will be good for 3 years. However, each year it has to be sent to the IRS. So what are the effective dates? The community health needs requirements are effective for hospital tax years beginning after March 23rd, 2012. The Treasury and the IRS requires the hospital to conduct this assessment and adopt an implementation strategy for each facility by the last day of its first taxable year. So here's just some examples. If the hospital has a June 30 fiscal year end, then by June 30, 2013, they have got to have conducted the community health needs assessment and adopted the implementation strategy. Now, one of the reasons why I would advocate early implementation of this is because on that June 30, 2013 990 tax return, the hospital is going to have to report the community benefits it gave during that fiscal year 2013 year. So you would want those community benefits that are being reported for that year to tie in to your needs assessment and your implementation strategy. So ideally, you would want to have that needs assessment and implementation strategy completed by June 30, 2012. So then you could be tailoring your community benefits in that fiscal year 2013 to tie back into those needs that were identified. As I mentioned, comments need to be submitted to the IRS on or before September the 23rd. These are the addresses which you can either mail them or you can submit them online by electronically to the IRS. And I know there's a number of hospital associations that are doing that. So that pretty much completes the presentation portion. If anyone has any questions, I would be glad to try to answer these.
Remember, if you have a question for Cindy, please press *pound on your phone, and you can then ask her the question.
Oh, I see one that's been typed here that says, can a community health needs assessment be regional? When you say regional, you can collaborate when you say regional, if those hospitals are actually serving the same population, you can collaborate. However, each hospital is going to be required to file a separate community health needs assessment. You're not going to be able to do a regional assessment and then duplicate that, run that through a copier, and then hand it out to each of the hospitals. It's going to have to be something that is specific for that particular hospital. But if the geographic population, or however you describe your community, is the same, I think you certainly could collaborate on some of the data gathering for your needs assessment.
This is Dave Palm from Nebraska. I have a couple of questions. One, just a clarification. I'm assuming that when you talk about addressing all of the needs, is that all of the priority needs or just all of the needs identified in the community needs assessment?
The IRS states all of the needs identified in the assessment.
Okay, very good. And my second question is, what would constitute a service area? For example, hospitals have patients from multiple counties, although in some cases it might be just a few, and in other cases they might have quite a concentration of patients. Is it up to them, or?
Well, right now the IRS is leaving it up to the hospital to define that service area. I know some hospitals may want to go into their patient records and look at their patients by zip code areas to say this is where we are drawing our patients. You know, these are the locations in which they live, and we define that as our primary community or our secondary community. I know some are doing it strictly by county lines. I think, though, as far as the needs assessment going, when you are having to describe the process and the methodology you use, that you need to have a good description as to how you chose that. The big requirement that the IRS has got in there is to make sure you are not excluding any of those four groups, regardless of how you pick it, that you did not exclude those four groups. But I think the logical thing would be is to look at the service area of the hospital by the actual patients they are seeing.
Very good. Thank you.
Does anyone else have any other questions for Cindy? Yeah, I did want to note one thing. We have done a TASC 90 call earlier in this program year, actually last August, on community health assessments, and talked a little bit more about the process of conducting a community health assessment. And on that call, Cheryl St. Clair from Rural Health Work, Sally Buck from here at the National Rural Health Resource Center, and then Natalie Claiborne with the Montana State Flex program presented on various different approaches to conducting community health needs assessments. So if you're looking for resources on that or are interested in and want to review the recording of that, you can access that on the TASC website. On the menu bar on the left side, there's a button that says events. You go on that and then scroll down chronologically back to August. You'll find the posting of the presentations and the call recording. We also have some various other resources on the TASC website too, pertaining to community health needs assessment. And then, of course, Tammy Norland with our staff here is our community specialist and has expertise in that area as well. And we do know that Rural Health Works received some federal funding to put together a template tool on conducting community health needs assessments that will be available shortly. I'm not exactly sure on the date, but when that is available, we'll make sure to disseminate that to everyone too. Any other comments or suggestions for Cindy or questions? Okay. I think with that, then we will move into our last presentations for the day, but certainly not the least. George Pink is joining us. George is a senior research fellow at the North Carolina Rural Health Research and Policy Analysis Center, which is part of the FLEX monitoring team. And there, Dr. Pink teaches courses in healthcare finance, is involved in several research projects, including the Rural Hospital Flexibility Program evaluation. He directs the component that involves dissemination of indicators of financial performance and condition of critical access hospitals using data from Medicare cost reports. And George is joining us here today to talk about the critical access hospital finance indicator reports, which will soon be mailed out to every individual critical access hospital in the country. And so it's a very important report and has some really interesting and unique information for each and every hospital. And so we wanted to make sure that we could highlight that in a timely way before all that information goes out. So with that, I will turn it over to George. And just a reminder to press *# to unmute your line, George.
Thank you, Nicole, and thank you for the opportunity to talk about our reports that are coming out next week. I'm just going to talk very briefly for about 10-15 minutes about these three things. What is the Financial Indicators Report? Because I understand there are some people on the call who have not seen this before. What kinds of resources are available to the state flex coordinators from our website, and then a couple of new studies that we're about to publish as well. So for those of you who have never heard of this before, very briefly, the CH Financial Indicators Report is a report that every critical access hospital in the country receives. It's got 21 indicators of financial performance that measure profitability, liquidity, capital structure, and a variety of revenue, cost, and utilization indicators that help us understand better the financial indicators. There are peer groups. There are 24 peer groups, so every hospital in the country is assigned to one of 24 peer groups, and then we calculate data based on those peer groups that hospitals can compare themselves to, so that allows an apples-to-apples kind of comparison. There are 5 benchmarks that were developed through a survey of CEOs and CFOs 3 or 4 years ago. And then new this year is a proposed financial distress model, and we're anticipating getting a bit of a reaction from that in terms of hospitals that are, well, I'll talk more about that in a second. So this slide is incorrect. You will not have received a snail mail letter from us yet. It's going to be going out next week. The reason is we've got more reports available for you this year, and as a result, we found that our website was getting a little cluttered and more difficult to use. So we have redesigned the website to make it easier for Flex coordinators to access and understand all the data that are available to them. That's taken us a little longer than we had anticipated, but you should get a report. You should get a letter by the end of next week, beginning of the following week at the very latest, certainly before the end of August. And then when you go to our new website, there'll be hopefully we hope you will find it'll be an easy to navigate a menu of different resources that are available to you. And essentially, we're dividing them into 3 categories: state-level resources, hospital-level resources, and other resources. So the state level resources, which presumably are the ones that you would be most interested in, for the first time we've put together a 2-page summary of findings for your state. This is response to several suggestions. I think Patsy Whaley was one person who suggested this. Some other Flex coordinators we've talked to as well thought it would be great, through this great massive pile of data that you give us every year, if you could give us sort of a 2-page summary of what are the major, the significant findings for the state. I'll talk more about that. I'll actually show this to you in a minute. The state graphs, what those shows you are for every indicator, all 21 indicators. It shows you the distribution. So we plot every single hospital in your state on a graph, and you can see at a glance where how your state is doing from sort of the highest to lowest. So it's the complete distribution from a statistical point of view. State data, this is an Excel spreadsheet, so we give you all of our indicators for every hospital in your state on an Excel spreadsheet, so you can do your own graphing and numerical analysis if you like. Again, if you're going into a particular hospital or a group of hospitals, you may want to grab the data for those hospitals alone. So this allows you to do your own analysis if you decide that that's important. And then finally, there's a book, a PDF file that's got all the state medians. So for any state in the country, you can see what the median value is. So if you live, if you're interested, for example, in the values of an adjacent state, you can go there and simply look it up. Then as well, you will have access to all the hospital level resources. So all the state level resources are only available to the state Flex coordinators with the exception of the medians document. But you will also have access to all the resources that are being provided to individual hospitals. So again, this is new for this year. We've put together a hospital summary, which is a 2-page summary of findings for an individual hospital. So if you've got 36 hospitals in your state, you will have access to 36 2-page summaries, one for each hospital. And the same is true for the hospital report. That is the detailed report that's about 35 pages long, that's got all the nitty-gritty, the definitions, the interpretations, and so on for each hospital in your state. Hospital graphs have got essentially the same graphs as you got for the state, except individual hospitals are highlighted. So if you want to know, if you want to see where XYZ hospital looks, where they land in the distribution of profit margin, for example, you can get that from this document. And then finally, at the bottom of the hospital cover letters, some state Flex coordinators have told us they've been contacted, that they've lost their letter from the Flex team telling them their username and password. So we're going to give you access to all the hospital cover letters so you can provide that if you get asked. And then finally, the other resources that are available to you, there's a presentation, a PowerPoint presentation, which is only 20 pages long. Essentially, hospitals use this to present the results to their board in a simple way. There's a calculator, which if you were interested in calculating specific values yourself for any particular hospital, you can do that. There's a primer. Those of you who are unfamiliar with financial analysis, this is an extended discussion, 95, 98 slides on how to interpret financial ratios and specifically how to use the data in the Critical Access Hospital Financial Indicators Report. And then there's a link to all the Flex monitoring team reports and data as well. So that's what you will find on the website when you get the letter from us giving you your username and password. So this, I want to just briefly go over this. This is what the two-page state summary will look like, and we're going to go over the report for Minnesota because Minnesota is looking pretty good these days. I don't know if the state Flex coordinator for Minnesota is on the line or not, but I'll be intrigued to see if this coincides with your understanding. So the first part is an executive summary for Minnesota. You see the first part is essentially how does Minnesota's financial performance in 2009 compare to last year, and then how does it compare to the country as a whole. And so you'll see that there's sort of a brief, faded about the same category in the column. Essentially, that is determined using a statistical rule, which I won't bore you with. But essentially, what we wanted to get at is if the median total margin this year is 4% and it's 4.1% last year, we consider that to be about the same. However, if the total margin is 4% this year and it was 1% last year, that we think means that it's higher. So we've used, I think, a reasonable statistical tool to make a judgment about whether the rate is, the value of the indicator has changed or not. So you can see that compared to last year, Minnesota is about the same on almost every indicator except for Medicare revenue per day, which is higher. Now, compared to the country, you can see Minnesota is quite different from the country as a whole. It's got a higher total margin, higher cash flow margin, and a higher operating margin. It's got higher days revenue accounts receivable, and so on. It's got lower patient deductions, which is good. It's got lower Medicare inpatient and outpatient mix. I don't know whether that's good or not. It depends on your perspective. And it's got lower salaries to net patient revenue, higher FTEs per adjusted bed, and lower average daily census. So we're hoping that this will provide state flex coordinators with a quick look at what's happened to what does it look like this year compared to last year, and how does our state compare to the country as a whole. The next report that we provide is a summary of benchmarks. So for example, we have 5 benchmarks currently. Minnesota, the median, the benchmark values, you can see the benchmarks are in the table. The cash flow margin, the benchmark is 5%. Days cash on hand, the benchmark is 60 days, and so on. And you can see that in Minnesota, 80.5% of all critical access hospitals meet the benchmark in cash flow margin, compared to only 53% for the country as a whole. So again, this is evidence that Minnesota is doing pretty well on profitability. Similarly, 61% of the hospitals in Minnesota meet the benchmark for days cash on hand, compared to only 52.8% in the country as a whole. And again, more evidence that Minnesota is doing quite well. So we're hoping, again, this gives you a nice little summary of how Minnesota is doing in relation to 5 CEO, CFO determined benchmarks. These are not grabbed out of thin air. These are not the result of a literature review. These are a result of 350 people telling us these are good values to compare to. The next is essentially a summary of giving you sort of the raw data. This is, for those of you in statistics class, this is a cats and whisker or box plot. Essentially, if this blue shaded box is skewed to the right of the graph, for example, days cash on hand, that tells you that on average Minnesota is doing better or has a higher value than the average in the U.S. On the other hand, for Medicare inpatient mix down here, the value for Minnesota is skewed to the right-hand side, and so that tells you that on average Minnesota has a lower value for that. This just tells you, essentially gives you a sense of the entire distribution of values versus just the median. And then finally, as I said a minute ago, one that I think we think is going to be provoke some comment, at least we're hoping it will, is our proposed model of financial distress. Essentially what we're doing there is we've developed a model based on assessment of literally hundreds of different variables, and we came up with this parsimonious model that essentially uses a variety of financial measures and a variety of market characteristic measures to predict the financial distress of a hospital 2 years later. So what we're doing here is these data are based on 2009 data, so This is the risk of financial distress in this table here is the risk of financial distress in 2011. So we're using 2009, 2008, 2007 data and trends in those data to predict which hospitals are going to be in financial distress in 2011. If this model is well received, if we get positive feedback or if we get some constructive criticism, then what we will probably do is move this model to more of a predictive model. We'll be using the model to predict future financial distress. So that will hopefully give the hospital and FLICS coordinators a heads up that if trends continue, this hospital is going to be in trouble next year. So essentially what we did is we used a model to assign all hospitals in the country to one of four buckets. Those at low risk of financial distress, those at mid-low, those at mid-high, and those at those at high level financial distress. So you can see that for the country as a whole, we've assigned 813 hospitals as having low risk of financial distress. And on the other hand, there's 124, about 10% of hospitals that we think are at fairly high risk of financial distress. Minnesota is very fortunate. It has no hospitals predicted right now to be at risk of financial distress. Now, I do want to emphasize that this is a financial model. There's a lot of data that would affect the risk of financial distress that is impossible to capture in a financial model. For example, if a hospital has just recruited a couple of new surgeons or 3 or 4 new primary care docs, we don't know that, but that would certainly have an impact on the financial distress of the hospital. So the model is not perfect. We don't claim it is, but hopefully it will give some predictive information to the hospital boards and state FLEX coordinators about who might be in financial trouble. We are asking for feedback, and you'll see this in the report as well, that whether this is helpful to you, whether you believe it or not. I suspect we will hear from hospitals that are in this group, the 124, who don't consider themselves to be in financial distress. I'm not sure we'll hear from any in the low group who think they are in financial distress, but we'll see. So if you want to know the nitty-gritty of the financial distress model, what goes into it, you can download this PDF document from the FLEX Monitoring Team website. And then finally, just a couple of studies that are relatively recent. There's one that's just been published in the Journal of Rural Health on the adoption and perceived effectiveness of financial improvement strategies. What this was a survey that we did last year, and we gave hospital CEOs, a menu of about 44 different strategies and approaches to improving financial performance. And we had hundreds of people reply to this. So this is an article that summarizes what they thought were some of the financial improvement strategies that actually work. So this is based on a large number of people. And then an article that we're just writing, which will be hopefully published soon in the Healthcare Financial Management, is we've followed up with 18. We identified 32 high performers, 32 high-performing CAHs, and we did detailed interviews with the CEOs of 18 of them, and we've written up the results, the lessons learned from those, how they achieved financial performance, and hopefully that will be available soon. And I'd be happy to answer any questions or any comments anybody has. Thank you.
Thank you so much, George. I think this is really exciting, and personally, I'm really excited about the financial distress model. I think it's really interesting and unique. So, does anyone have any questions for George? Again, it's *# to unmute your line.
Tracy?
Yeah.
This is Kevin, and I'm wondering, Kevin Driesen, George, do I understand then that you will be informing the hospitals that have been identified as being distressed? You'll be sending them information about that understanding? Or are you still looking for feedback on the hospitals that have been identified before you inform them about your assessment?
No, we have thrown caution to the wind, and we are including in the reports that the hospitals get. And again, all of you will have access to the individual hospital reports, so you will be able to see the financial distress reports for any hospital in your state. But there's a three-page financial distress report in every single hospital's the COFR, the financial indicators report that they're going to be getting in the next 10 days. So that's they will, and we tell them explicitly, based on the data that we've got for your hospital, you are at low risk, you are at high risk for financial distress. So that's what we're hoping that's what we're expecting will prompt some response to the model.
This is Tracy again. I'd also like to mention that Nicole Clement recently sent out an email to each state flex coordinator requesting your assistance with compiling a CAH administrator's email list. And the purpose of that email list is really truly to support the flex monitoring team with this initiative or other initiatives they might have, or HP as well. We've used it in the past to communicate at the time that these reports are going out, that they're coming to the critical access hospitals just as another venue to make sure that the letter isn't lost in the mail. And I know Nicole has noted that she's received about responses back from about half the state flex programs. And what we're looking for is just updated contact information for each of your critical access hospitals in the form of both their mailing address and phone number, but most importantly, an email address. And what we do with that is compile an email list, just like we have multiple different listservs here, and send them a message just indicating that this critical report is coming out to them. And then at the same time, we'll also notify the flex coordinators that we'll copy you on the email as well, so you'll see exactly what went to them too. And in the past, that's generated actually a lot of emails back to TASC from the individual hospital saying, I didn't get the letter. Can you point me out to where it could go from, or where it came to, or whatever it might be. And from there, we forward the information on then to North Carolina, who responds. So it's actually really important to not just assume that they're receiving the information via snail mail. And this has been a good method, I think, in the past to connect administrators into receiving the reports. Especially, it's happened quite a few times where even months later we'll get an email saying,